Eddie? Well, good evening. I hope everybody can hear me. This is the first time we've done a webinar as opposed to an in-house class at the hospital. I want to thank Tanner for putting this together. This will probably take maybe 45 minutes. It all depends on how many questions we have at the end, which I invite questions. So I'm James Cullison. I'm a physician. I've been here since 2004. I'm a urologist and female pelvic medicine and reconstructive surgeon. That's sometimes abbreviated as FPMRS. I've spent a lot of time treating and operating and doing procedures on female pelvic health conditions. Some things I won't cover here, but if you were to see me in the office and find that some of the things I don't cover that aren't in here and that I don't do, I can certainly lead you in the right direction. So I'm going to go through a lot of things. At times I may go a little fast just because there's a lot of material, but I'll do my best to explain each slide the best that I can. You may or may not be able to see my mouse on the screen, which I'll sometimes use as a pointer. If you would like to ask a question, you can find a box that says ask a question. It's a button. It'll ask whether you want to make your name anonymous or not and ask the question. If you don't see that box, look in the top right corner for the button. So we're going to go over several complaints of the pelvis that I can sometimes see in my office. This can be bladder control issues, whether it's leaking with urgency or stress, storage issues, may not be able to hold very much volume. You can have bladder pain issues that cause urinary frequency or basically somewhat of a cramping pain that you can get from a lot of reasons, which we'll go over. You might describe just a generalized pelvic pain or urethral pain. If you even know what the urethra is, we'll cover some of that. It almost feels like a stabbing pain in one little spot. We'll go over some bowel control issues. We'll go over urinary tract infection. That's a very large topic. We'll kind of go through that briefly. And then we'll go through some discomfort with intercourse type problems. We'll start with some urinary control and storage issues. This is the largest volume of what I see in my practice. And, you know, this can be many different complaints. This can be your complaint of going to the bathroom too much, urgency, getting up too much at night, which is called nocturia. You may have leakage of urine associated with urgency, such as when you turn the water on and you can't get to the bathroom in time. There's also stress incontinence, which is typically an activity related leakage. This could be like if you're swinging a tennis racket or you're just bending over or you cough, you sneeze, or you laugh. Then there's those that can't empty their bladder all the way and they have a constant feeling of pressure. They have an increase in urinary tract infections and sometimes require a catheter. We'll do overactive bladder first. This is probably the most common bladder condition in the United States. It's underreported. It's estimated to be about 13 million people suffer from this. Overactive bladder is basically a term of urinary frequency, urgency incontinence. Overactive bladder was not a term we used in the 90s. I think it actually was coined by a drug company, to be honest with you, when Detrol LA came out and we started using the term overactive bladder. But it's usually if it involves 2 or 3 of the symptoms of frequency, urgency, or urge incontinence. Urge incontinence is basically having an urgency to urinate and you end up leaking and not getting to the bathroom in time. So we'll start with some of these treatments for the overactive bladder or urgency. There's a lot of conservative ones we try to work with you on. We're actually required to do this from an insurance standpoint if you want to move to more advanced treatments. We will tell you to make sure you're not drinking an excessive amount of fluid. That seems to be a fad these days. We'll ask you to double void, which means sometimes urinate, wait a few minutes and urinate again. That does a certain neurologic response in training. That's difficult to explain, but they can cut down on your urgency. Kegel exercises people are familiar with. We'll talk a little bit more about these later. There's a pelvic floor stimulation therapy that we'll go over. We still consider that conservative. There's multiple medications. We will treat conditions of the vagina that can sometimes lead to urinary urgency. And then we'll talk about correcting bowel issues and any type of bladder pain syndromes that can lead to urinary urgency or overactive bladder. This is a relatively brief slide. Basically, the non-surgical treatments are going to involve some sort of an exercise, taking medication, or some pelvic floor stimulation therapy that's not new. It's been out for a long time. Those pictures there are showing different kind of exercises. These are not Kegel exercises. These are somewhat similar to some things I'm going to say at the end of the presentation. So everybody is familiar with these commercials on TV. Down at the bottom right, you see the little pink person or pink object that pulls the lady around on the television commercials. That currently is the #1 prescribed medication in the United States, called Myrbetriq. It is kind of in a class of its own. It's a beta agonist, unlike all the traditional medicines, which I'm going to cover in a minute. This one to the left was Vesicare, that had the little walking pipes. That was on the TV for the longest time. That was the previous most commonly prescribed medication. And so there's a long list of medications, again, for just overactive bladder, frequency, urgency, and urgency incontinence. I've listed Myrbetriq at the top, and then Vesicare. Vesicare is an anticholinergic. It is still our most popular anticholinergic medication. All the ones below it have all some anticholinergic properties, which basically relaxes the bladder. And all of these can have a myriad of side effects, which are a concern, which are constipation, dry mouth, blurry vision. And more recently, we've been focused on the concern of dementia, which I'm going to go over a little bit. So Vesicare and down in that list is on the list of medicines that can cause dementia. And those that have suffered with overactive bladder has certainly been on some of these medicines before. And so we typically try these medicines first, and typically the insurance company wants us to do that before we would ever consider any type of advanced treatments. But here's the comment about dementia. We've kind of always known this. However, last year, earlier in the year, there was a very large study, very large cohort of patients that they reviewed, multiple thousands that were taking several different types of medication. And it was found that those that were taking anticholinergic medicines, especially those used for bladder control symptoms, there was an increase in dementia. And basically there was a comment that I pulled out of this article that is in bold, well, excuse me, that is underlined, that I have down here at the bottom. I'm going to read that out, which is really the concern that I have. And in this study, there was nearly a 50% increase odds of dementia associated with total anticholinergic exposure of more than 1,095 total standardized daily doses within a 10-year period, which is basically being treated with the medicine for 3 years of use, was considered a strong anticholinergic, which the bladder medications are considered strong anticholinergics. And that was the minimum dose to cause dementia at a 50% increase later in life. So that was relatively substantial. We actually had this as a handout now. This is not bled into the insurance companies. I'm not picking on the insurance companies. They are not using this as any type of criteria, but we're well aware, and we want to make sure the patients are aware of this when they seek treatments for overactive bladder. Kegel exercises. This is a very old photo. I use it just because I can't find one that's as good as this one. Down where you see on this left side of the screen, the arrows, they're pointing out, there is a circular muscle on the urethra tube that's about 2 inches long. It's the one, if you were urinating and suddenly cut off your stream, that is the muscle. So a Kegel exercise is where we teach you how to actually contract and relax that muscle. And we always start with saying, you know, sit down to urinate and stop your stream halfway through very abruptly, and that's the beginning of learning how to do a Kegel exercise. This is the stimulation therapy. I wouldn't really consider this an advanced therapy. I still consider this a conservative therapy. I always say this kind of therapy is a function of time and money. There is no risk. You do have to come to the office, and a probe is placed in your vagina that stimulates that same muscle we were talking about that goes around the urethra. It stimulates it, and then it relaxes, and then the computer system that's hooked to it will have you contract it on your own and relax. So that's pelvic floor biofeedback and pelvic floor stimulation therapy. This is a very good conservative option to help with overactive bladder. We had this in the office. We've had it for many years. So moving on to less conservative options, which would be somewhat treatments or surgery. And these would be the things that we would do for overactive bladder of urgency frequency and urgency incontinence. Again, not stress incontinence. So a neurosystem is one of these minimally invasive treatments we do in the office. It has another name called urgent PC. They're the same thing, but basically this is a sacral neuromodulation, which is a modality of nerve treatment that basically can control your bladder. And this is a peripheral nerve. So this is, again, an outpatient office treatment that really doesn't have any side effects. It does require many trips to the office. So again, I would say it's a function of time and money with low risk. Here's a picture of it here. To the left hand of the screen, there's a little, somewhat of an alligator clamp connected to a little tiny needle. This is a floppy needle. So what we're doing there is we're placing this needle just behind your ankle. Believe it or not, there is a nerve, the posterior tibial nerve, that lives right there. And that's just a sensory nerve. However, looking at this other slide in the middle, you can see this yellow line going up the lady's right leg. That peripheral nerve just happens to go to the same level of the sacrum where your bladder nerves are. And why is that important? Well, when you stimulate this nerve, it retro sends the signal back and trains these nerves that go to your bladder. Believe it or not, that works. And that's sacral neuromodulation. This is carried out percutaneously without surgery. And you're basically training the nerve. So this, they've done head-to-head studies with doing this office-based treatment that is typically paid for by your insurance. They've done head-to-head studies, which is as valuable as medication, but doesn't endure the side effects. And a lot of people don't like to take medicine. And so basically it's a small needle, 34 gauge needle is small. It's going behind the ankle. And what it is 30-minute sessions once a week for 12 weeks. And basically you can come back from time to time and get a little tune-up, I call it, and just to remind that nerve of the neuromodulation. And I find it comical. They show a picture of this person. You really don't have to do anything. You read a book or bring your iPad, and we just hook you up to the device, and it's 30 minutes long. And this just, I'm not going to spend a lot of time on this slide. These are some studies that made the New England Journal of Medicine, which again is one of our biggest reference impact journals in the world. And basically they were showing in this study that it was as good as medication, but didn't endure the side effects. They also did another study where they did a sham procedure where they literally put the needle in but didn't turn on the power, and the sham did show that they weren't as well off. They still had overactive bladder symptoms. And then this last study showed the long-term efficacy of doing the peripheral nerve sacral neuromodulation. Bladder Botox, yeah, it looks like in medicine we use Botox for a lot of things, cosmetics, headaches, a lot of other things. Believe it or not, we've been using bladder Botox for over 10 years, probably started around 2008. And it is an office-based procedure as well. So this is an invasive treatment, but it's not surgery. And this works. It does involve us putting a telescope in your bladder and using a very small needle. It's only 3 to 4 millimeters long that we inject into 20 different locations of the posterior wall of your bladder and put a very small amount of Botox spread all throughout the bladder. And that basically paralyzes the muscle, just like what Botox does. It's a paralytic. Well, we're just putting the safe dose just to relax the bladder or paralyze it just enough so you don't have to go to the restroom all the time. It gets rid of urgency and frequency. It's a little more invasive. It can cause a urinary tract infection. You can have some burning with urination for a little while. And every once in a while we get somebody that the treatment really, quote, worked too good and they can't urinate for a short period of time and they require a catheter. But it is much more effective than the medications. And so it's somewhat of a middle of the road option of invasive procedure without having to have surgery. So we have many people who come every 6 to 12 months and have this repeated, and they choose this as opposed to taking medication, or the medication has too many side effects and they don't have much choice. So moving on to surgical implants, I've been doing this for 20 years. There's been a lot of press on this lately, and the reason is because the technology has gotten a lot better in the last few years. To the right of the screen, it's showing you some of the modern day implants. And these implants have many therapeutic benefits. You can use them for overactive bladder. That's why I stuck it at the end of this session of overactive bladder, this segment of the talk. But just to go ahead and throw it out there, it can work with neurogenic bladder conditions, those that cannot empty their bladder, interstitial cystitis, which is a painful bladder syndrome, pelvic pain, and bowel leakage. It is FDA approved for overactive bladder, urinary retention, and bowel leakage. And I'll get to more of that later. Here's a picture to the left and right of two competitors, basically. But if you're able to look at the screen, you basically have an implant that goes in your upper right buttock area below the belt line. And it is a neurostimulator that's hooked to a cable system that does not go in your spine. It goes in your sacrum, around close to your tailbone, and these already holes that are in your bones. Your nerves live on the other side of this bone. So basically it's just a power device hooked to a cable that sits next to your bladder and bowel nerves. The image to the right shows the cable, if you can see it, going inside this hole, this natural foramen, and you can see that the cable is laying next to a nerve. So we're not sticking it in the nerve, we're not sticking it in the spinal cord, we're just laying it next to the bowel and bladder nerves in order for sacral neuromodulation, and in other words, controlling those nerves. And it comes with a remote. This is one of the remotes. It shows this one hooked to a keychain. And I'm not going to go into details of the remote, but there's a simple way of making changes to the device. I will tell people that, learn how to use the remote, but basically I do all the programming in the office, and sometimes the reps from the company will also call you and help with some of the programming. But once we get it set, you don't really have to do much with it anymore. And it's a natural sensation. You have bladder and bowel control, and you forget you have the device in place. And that's what's so great about it. So this is probably the gold standard of bowel and bladder control. In order to see if you're a candidate for this, it's an expensive device. Insurance typically will cover it once we've tried conservative therapies. There's a test in our office where we put a temporary version in for a week so that it can prove to yourself that the device is working for your bladder or bowel conditions. And basically a needle is placed right around here. This is where your tailbone is, your belt line's up here. But this is going in that little hole. We know how to put it in there, and we run this little tiny cable that we just tape to you, and you wear it for a week, and that is called the test. We're basically challenging the nerve with this stimulus to see if it controls the symptoms we're looking for. And that is the test that we do in our office, and you wear it for a week. It's minimally invasive. I always say it's like, I'm back here doing this, and you feel little bee stings while we're trying to find that little opening, but we do numb the skin. So overactive bladder and fecal incontinence is getting a lot more press just because of how prominent it is. Probably previously it was underreported due to embarrassment, but Interstim and Axonics, which is the newer implants, as you see, it's much smaller than my hand. It's a rechargeable device that lasts up to 15 years. And then Medtronic's now has a small one as well. And you can see that it has made progress over the years from the bigger one. So these require a very small incision on your backside. We're going to move on. That was overactive bladder mostly. We will go back to some of the bowel control issues and pelvic pain later. I do want to say something about surgical mesh, mainly transvaginal mesh. I don't want anybody to get offended at some of my comments if they think I'm being sarcastic. I've been dealing with implanting surgical mesh for 20 years. And everybody is familiar with these commercials, possibly this one that was on the TV 10 years ago or more. I would say the bad years were probably 2007 to 2011. I was putting mesh back in a decade prior to that, and there was no controversy. So there's a long story about that. If you ever come to my office, I can fill you in, but I'll briefly kind of go over some of that. There was another slide I had in here that we've taken out, but basically it said FDA warning. There was never a FDA warning on transvaginal mesh. There was never a recall, believe it or not. The billion-dollar companies that made them did voluntarily withdraw them from the supply chain, and the FDA did put out a notification and a safety, but no warning. So basically, this is a sling mesh that we are currently using today that has been out for over 20 years. There has been a change in models over time, but it's very similar to the original ones. And currently, the FDA does not have an issue with this product. I apologize if somebody got one of these products in the past and you had unfortunate results, but I feel we've overcome that. And in the last 7 or 8 years, these products have seemed to go in more commonly than they did in the previous decade, and they're used all over the world. So basically, this is a piece of material like you see at the bottom of the screen. Again, this is for stress incontinence. This is not for overactive bladder. This is for leaking when you cough, sneeze, and laugh. If you look at the top of the screen, you can see the little blue strip. This is the mesh going underneath the urethra. Again, it's that tube from the bladder that's about 2 inches long that goes underneath the urethra. Here is a close-up image of this. It's like a lattice. It's got a little bit of flex to it, but this is a device that is not absorbed. Your tissue grows through it in these thousands of holes. And basically it travels on the top of your vagina underneath the urethra, and your urethra sits on top of it, and this kind of serves as a backboard. So that adds urethral support. So this is really not a bladder tack, although it gets slang and language to describe it that way, but we're not tacking the bladder. It's basically support for the urethra. And I do these just about every week and been doing them for 20 years almost, basically. And I would tell you that this style of operation is done all over the world as the most common urinary incontinence surgery. These are some of the older products that did not fare so well on the market. There are many more than this, but I'm trying to give you an image. They basically were large pieces of transvaginal mesh. As you can see, the one in the left upper corner had a bunch of arms. There was another product that had 6 arms to it, and this was for vaginal prolapse, cystocele, rectoceles, interstitials. And I would go to any big meeting all over the world, out of the country, and all the most famous people who did transvaginal surgery would be lecturing us on using these products as this was the new next thing. Well, that ended up being somewhat of a disaster. So nobody is doing these except in select cases. They had complications, whether you want to blame it on the manufacturer or not, or how the surgeon did it, what have you, but they have been withdrawn from the market. Just to further my confidence in the urethral sling, this here is an article, just the top of the article, but I wanted to show you it's from the New England Journal of Medicine. Whenever some article makes it in the New England Journal of Medicine, that is the most reviewed and has the biggest impact on world medicine. It is the most read and most highly regarded. So basically, in 2012, this was after all the controversy, this particular study was allowed, and I find this to be a confidence builder in those that are considering a urethral mesh sling. And that is, in this study, women who had a prolapse repair, basically their bladder or rectum was basically falling out and prolapsing, and they didn't even have urinary incontinence. Well, this study was set up to put in a sling or not. The patient didn't know it. It was double blind, and the patient didn't even have incontinence going in, but they signed up that they may or may not get a sling at the beginning of the surgery in addition to their prolapse repair. And if they did not get a sling, they still got the incision and it was closed right up, so the patient never knew they got the sling. This was allowed, and what they found in this study, that even putting in a sling after a prolapse surgery improved the patient's quality of life. And then those later that found out they didn't have a sling came back to get a sling placed. So basically, they found that the benefit of the sling outweighed any potential complication rate. And so this slide here is talking about 2.4% of the women ended up getting the sling removed, as opposed to 5% of women went back to get the sling placed. And I can tell you, with doing this sling surgery over a long period of time in large numbers, the complication rate's less than 3%. Well, let me put it this way. The complication rate is less than 5%, but the reoperation rate is less than 3%. This is much improved over what I was doing in the late 90s with the more traditional surgeries where we were making the slings from scratch or doing urethropexies. A lot of those people stay in the hospital 3 days. They had a catheter for a longer period of time. So there's much less complications. And once again, I apologize if you know somebody or you or somebody that got a sling and you had unfortunate results. But the current going rate on this, the FDA has a handout that we have from the 2 largest pelvic health organizations on the FDA's clearance of sling and how it's the most studied and most studied and most commonly done urinary incontinence surgery. And this is a part of the handout that I hand out in my office whenever we set somebody up for a urethral sling surgery. And it's got a lot of statements of the FDA in here. Basically, like this bottom statement here, this is an FDA statement. The safety and effectiveness of multi-incision slings is well established in clinical trials that followed patients up to 1 year. So they are not against it. And see, this was talking about in 2011, the FDA safety communication. It wasn't an FDA warning. So why would I do this surgery? The surgery takes 30 to 40 minutes, which is amazing compared to what I did 20 years ago. The cure rate is very high. The satisfaction rate is very high. It's got low complications. It lasts a very long time. You have much less chance of a reoperation later for incontinence. Got a quick recovery. You just can't lift 5 pounds for 4 weeks. You can pretty much, I do a lot of these on Fridays, you can pretty much do most of what you normally do over the weekend even. Go up and down stairs and go for long walks and drive as long as you're not taking pain medicine. So that's stress incontinence. So we have covered overactive bladder, which is frequency urgency, and we've covered stress incontinence. So I'm going to talk some about bladder pain syndrome. It used to be called interstitial cystitis. Both of those terms are used more commonly in the literature now. It uses the word bladder pain syndrome. This can be associated with overactive bladder symptoms and have bladder pain at the same time. It can have burning when you urinate. You can have blood in your urine. You can just have pain in the lower abdominal area. And this is with, these are symptoms like this without any evidence of any infection. So if you were to search a gynecology website or a urology website or urogynecology website and wanted to know the guidelines, this is one page out of the guidelines. We used to be all over the map on treating this condition, but I treat a lot of these patients and I welcome these patients to come in because I will start them all over on square one. This is in very small writing. And basically, if someone doesn't sit down and talk to you about your behavior modification and what you are eating, you will never tackle this problem, okay? So I will always spend time with you. If you come to my office with this type of problem, I will spend time with you to educate you on the simple things that are necessary to even get started handling this. But there are 4 medications that are in the second line of treatments. A lot of people have heard of Elmiron. That is FDA approved for treatment of interstitial cystitis. I don't prescribe a lot of this. I always try people on amitriptyline and some other ones first. And we basically go over some other conservative things as well. When you get to the 3rd and 4th line management, we're now getting into the invasive procedures. Hydrodistension is a procedure I do at the hospital. That's fairly simple. We don't do that as much as we used to anymore, but we still offer it. The 4th line treatments, we do quite a bit. And please note that in the 4th line treatments, again, for frequency urgency associated with bladder pain, burning, that's not associated with infection, we're now back to Botox, intravesical Botox, and also neuromodulation, which is what we've already discussed. So those treatments are in the guidelines for bladder pain syndrome. That again is sacral neuromodulation. Earlier in the slide presentation, I did not say that the FDA it's not FDA approved for this condition, but it's clinically shown to help with this condition. It's in the guidelines. So basically, if you came to my office, we would have to say the literature supports that it does help these conditions. But basically, we would be putting the implant in for overactive bladder because you would have frequency and urgency associated with this. This sounds complicated and confusing. Be glad to explain that more in the office if you have this condition. We are not going to go over the 5th and 6th line treatments. Those are very aggressive. Not necessarily talked about today. I very rarely have to go that far. So the diet modifications, I got a long handout for interstitial cystitis. But we're going to go into some diet modifications for bladder basic stuff now. We're going to move on from painful bladder to bowel control issues. The workup for this is relatively simple. If you have somebody that can't control your bowels, there's not a lot of therapies that work. There's some conservative stuff, and then there's some surgical stuff. There's really not much in between. We will certainly go over with you some diet modifications. We would recommend you see gastroenterology to get their assistance with this. They want to make sure we don't have overflow constipation or irritable bowel syndrome or conditions like that. But we will certainly try some of the simple things with you in addition to what gastroenterology would do with you. They will get you up to date on a colonoscopy and help us with some of the documentation of trying the conservative options and do a manometry, which measures the strength or the control that you have of your lower colon, your rectum and anal area. So moving from conservative options. Now, there have been a lot of aggressive things to try to help with this because someone who has bowel incontinence really is a hermit. They just don't get out. They're nervous to go anywhere. Stuff like the Celesta, the Phoenix, sphincteroplasty, and artificial sphincter. These are not commonly done as much anymore. I was trained on the Phoenix, which is a circular ring of magnets. It was pulled from the market by Johnson & Johnson, and I bet you they'll release it at another time. Sphincteroplasty was commonly an operation done on your sphincter area in order to improve your control. This has a failure rate of 5 years, so it doesn't seem to be done as much. The artificial urinary sphincter, one of these has been taken off the market, I'm not sure. But regardless, Interstim and Axonics, sacral neuromodulation has become extremely common and getting paid for by your insurance. We have a lot of people coming to get this sacral neuromodulation, which we've already talked about. It does wonderful bowel urgency and bowel control symptoms. And again, going back to these devices, they are now small, it's battery powered, and it's hooked to a small cable inside of you, and it lasts for years, and it can do wonders for your bladder and bowel control issues, as well as pelvic pain and bladder pain syndrome. So cystitis, you could call that urinary tract infection of the bladder. You know, as I said, painful bladder syndrome can mimic a urinary tract infection, but it's actually without signs of infection, and you're basically having symptoms. Try not to pay a lot of attention to the left-hand side of the screen. Look at the right-hand side of the screen. You know, again, you can have, with an infection, the frequent urination, the abdominal pain, but in addition, with the infection on top of just having bladder pain, you can have some feeling unwell, just feeling sick, nauseated, fever. This is a huge problem. We see this every day in large volumes. They are flooding in the office, especially women postmenopausal. We are seeing just a surge in urinary tract infection. It's become a real problem. And we will actually spend a lot of time with you on this. We have a program to put you through to try to help prevent these. This article here has been around for a long time. It's kind of the staple of what you're supposed to do for a routine ambulatory urinary tract infection for those that just come to the hospital, not those that have a fever and go to the ER. And we try our best to stay with these guidelines, but it's very difficult because the complexities of treating a simple urinary tract infection has gotten much more difficult over the years. I'm going to explain in a minute. And basically within this article is this flow sheet. And I'm going to just really try to simplify the whole thing, is the guidelines of urogynecology, gynecology, and urology would all agree that treating somebody with a simple urinary tract infection with Cipro or penicillins is not what you're supposed to do. Patients will come in asking for it, but that is what we're not supposed to do. And basically using those type of antibiotics over and over causes bacterial resistance and can cause bowel infections. It can start making your urinary tract infections more bacterial resistant to our other medications. So those are never considered first-line treatments. The first-line treatments are macrobid or nitrofurantoin or Bactrim or sulfa. And basically that's only for 3 to 5 days. And that seems like that would not be enough. And sometimes it's not, but that is what we are asked to do. We are asked to prescribe those medicines first in those people who have recurrent urinary tract infections or just urinary tract infection for the first time. This becomes a challenge because sometimes it fails, or here's the thing, a lot of people are allergic to macrobid or a lot of people are allergic to sulfa. And this becomes an issue to where we have to move straight from that to fluoroquinolones and penicillin. But we try. And after we've seen you a few times and that becomes unsuccessful, we have to move on to more aggressive preventative therapies. Now, another problem is lately is our nephrologists really don't like us prescribing the Bactrim anymore, the sulfa. And our pulmonologists don't like us prescribing macrobid or nitrofurantoin for the fear of pulmonary fibrosis. However, those are still the first line treatments. This slide is a little incorrect, but basically I'm just reiterating that we try to adhere to the guidelines. We culture your urine or do a molecular study called a PCR where we get the results back in 24 hours most of the time. This has become very popular in our office. Sometimes the cultures take up to a week to get back, and that's made a lot of patients angry, but we have to rely on the technology that we have. But so all these organisms, this is going to shock a lot of people, and I have a hard time getting people to believe me, but these urinary tract infections come from yourself, you know, well over 95% of the time. We will get an ultrasound and we will screen you to make sure you're not passing a kidney stone, have a blockage, a mass, or incompletely emptying of your bladder or some other anatomical abnormality, but these are coming from yourself and nobody wants to admit it. They are coming from your vagina. Your vagina has millions of bacteria, and those bacteria in proportions change over time. So all those bacteria you see on the left are common organisms that we see on cultures. And that top one, that E. coli, is 60% of all urinary tract infections. It lives in our bowel. It's a normal organism, lives in the bowel. It lives in the vagina, but when it gets in the bladder, it causes an infection and is considered a pathogenic organism for the bladder. And if you get an overgrowth of that in the vaginal area, that sounds terrible. It just keeps climbing back in your bladder. You can just keep taking antibiotics over and over. It just keeps climbing back into your bladder and reinfecting you. But all these other organisms listed here can do the same. And all these organisms can become resistant if you abuse the treatment of urinary tract infections with high-powered antibiotics. So going through preventative options for urinary tract infections. Yes, all of us physicians can give you antibiotics at the time of an acute infection, but what do you want to do to prevent it? Well, focusing on hygiene, vaginal products, worried about bath versus shower, those have minimal impact on recurrent urinary tract infections beyond what many believe. We will bring some of these things up, but really it is more from what is living in your vagina, which sounds ridiculous, but that is the cause. Until somebody believes that, they're not going to start doing some of the recommendations that we make, such as number one on there, vaginal estrogens. Now, let me say something about vaginal estrogens. I do not consider this as a risky treatment compared to taking estrogens by mouth or topical estrogens to the skin. Vaginal estrogens, only small amounts get absorbed into your overall system. Most of it stays in the vagina area, and we're relying on it to absorb into the tissues to make your tissues healthier and to cut down on urinary tract infections. I'm going to go over the histology of that a little more in a minute. But as you see, I put a number one on there. The first thing we are going to offer a postmenopausal female is vaginal estrogens, hands down. We will not offer that to those that have had a history of breast cancer or deep vein thrombosis or clots that have flipped to the lungs. We won't do that. But in anybody else, we will offer that to you because it is the most studied preventative treatment for urinary tract infections. And so it can cost some money. Sometimes your insurance won't pay for it. We have ways to work around that as well. Some other things I'm going to mention these are not in any kind of order of favor. Cranberry extracts have been known to help. There's a popular product on the market now called Allura that's got a high concentration of cranberry. It'll cost you $45 a month. I'm not advertising that. I'm just telling you it's out there. It's getting a lot of press lately. D-mannose and apple cider vinegar. Believe it or not, a tablespoon of apple cider vinegar a day, if it doesn't cause you gastrointestinal problems, it's helped a lot of people and it's very inexpensive. A lot of times you can just mix that with water. Hyaluronic acid suppositories. Hyaluronic acid is already in our body. There is a company that sells suppositories. This is not a prescription. You have to buy them online. You use them once a day. And basically, when you add hyaluronic acid to your vaginal area, it does many things. It helps with some of your own natural secretions. It makes the secretions more acidic, the environment more acidic, and pathogenic bacteria don't like that, and they will go lower in numbers. Plus, you'll increase your number of lactobacillus, which we'll go over a little bit more in a minute. That's a good organism. Hiprex or methenamine hiprate, that is a medicine, is a prescription that's not an antibiotic. It makes the urine acidic and kind of gives it a formaldehyde kind of basis or kind of a feel to it, and bacteria don't like to grow in your urine when you're taking this prescription. Macrodantin or Bactrim prophylaxis, yes, those are antibiotics, but you can use those in low dose for intervals to suppress the growth of urinary tract infection. That is still recommended in the urology guidelines, is putting someone on that for a while and then take them off. And then refined coconut oil. We have a lot of patients on this now. We've learned this from lectures around the country of women starting to use this. This is kind of a paste. We kind of teach you how to use it in the office, but if you use this on the outside of the vagina and just inside a little bit, that also can cut down on urinary tract infection and help with other things as well. So treating the vaginal tissues, I'm kind of morphing from urinary tract infection into treating vaginal tissues because that's kind of what we do when somebody has recurrent urinary tract infections. We get you on a program and start with trying to change the vaginal environment, for lack of better words, and make sure you're not doing things to make it more toxic. But these unwanted vaginal symptoms, basically itching, burning, dryness, irritation, pain with intercourse, these are where the tissue of the vagina, especially post-menopause, have got to where they don't have as much vascular supply or secretions. The cell layer has changed. Some people get a condition of lichen sclerosis that is a lot more common than you think. That is where the vulvar and the introitus area is contracted and the skin has become dry and flaky and cracks easily. Paravaginal tissues, I've already said, when it becomes diseased, you can get urinary tract infections, and also it can contribute to some mild urinary incontinence. So treating those tissues can fix a lot of these problems. One is, again, is we would offer vaginal estrogens, and we also have other topical type creams we prescribe as well. Here's an example of change of your vaginal lining. Let's ignore the far left pre-puberty for right now. So during your years where your ovaries are producing estrogen, your vaginal lining is thick. It has a lot of lactobacillus and good organisms on the surface. And in the deep layers, you have a lot of epithelial cells. The epithelial cells of the vagina are the ones that have all the nice secretions. You want to have a lot of those. You want that to be thick. It keeps the pH low. Bacteria, pathogenic bacteria, don't like living in that environment. Lactobacillus prevails. That is also in probiotics, which is a story for another day. But anyway, so you increase your good organisms, you decrease the pH, it becomes thick, lots of secretions, and that is the healthy vagina that prevents and maintains an environment that prevents these symptoms and problems from the previous slide. So postmenopausal, if you look at the right, what you have is those that have that are on basically hormone replacement therapy, just transvaginal now. And basically you can see you're starting to build back more of the lactobacillus and making more epithelial cells that make the secretions. When you have a less number of those cells and less secretions and less acidity, you start getting pathogenic organisms growing and getting all kinds of vaginal symptoms. Well, we offer Mona Lisa Touch in the office as something that you can try in addition or as an alternative to vaginal estrogen. Maybe you're uncomfortable with it, maybe you can't afford it, maybe you find it too messy, you don't want to be on a medication. The Mona Lisa Touch is a CO2 fractional laser that we do in our office on a few Fridays a month to address all of those vaginal symptoms that can lead to the dryness, the irritation, pain with intercourse, urinary tract infections, just overall vaginal comfort. This is an alternative that it works fantastic. And basically it's a fractional laser that makes these little tiny microscopic incisions all throughout the vagina and on the outside of the vagina. This laser makes these small nicks to promote healing and brings in the epithelial cells that I was speaking of, again, to naturally increase your own secretions and naturally bring in the good bacteria and naturally decrease the pH. You can see this in this slide here. This far left is someone who basically has an atrophic vagina that doesn't have any epithelial cells. These are basal cells. They just sit there as a lining and do nothing. They offer no protection, no secretions. But when you have Mona Lisa Touch, which is similar to taking vaginal estrogens, you see that you have stimulated this epithelial growth. And this is the tissue cell layer that basically makes all the good secretions and good bacteria in a low acidic environment. And basically that's a 5-minute procedure. It doesn't have any pain. It's up to 3 times 6 weeks apart. Insurance doesn't pay for it. We do have payment plans for this, but in the end, if you were to have this done, let me back up. If you were to have this done, you'd get 3 treatments, and you may consider coming in once a year to get kind of a tune-up of the tissue. We've had some people come in more. So this basically does a lot of things to get rid of unwanted vaginal symptoms that are associated with either the lining or just behind the lining of the vagina. We're going to move from this to talking about pelvic pain or pain in the vagina that's not really visceral, which means not from the ovaries, not from the uterus. There are some pelvic pain from those things that we would send you to your gynecologist that they would take care of. They would do a transvaginal ultrasound. There are effective treatments for that. But when I'm saying non-visceral, I'm talking about those that get pain from things that aren't their ovaries. They aren't their bladder. They're not their bowel. They're basically from nerves, ligaments, tendons, and muscles throughout the pelvis. So somebody who has lichen sclerosis or vaginal atrophy or vaginal itching, per se, this would not be something I'm calling non-visceral pelvic pain. What I'm referring to is those parts of the pelvis that have lots of tendons, attachments, bone. You could have cartilage and whatnot. So there are a lot of women plagued by pelvic pain, pelvic symptoms that they go to physicians and they don't get an answer. They can try different ointments, topical creams, over-the-counter medicines. They can try prescription drugs. They can try surgeries and all that. And basically, the doctors just get to where they don't have as much to offer. And now I can do a full vaginal and pelvic exam on you, and I can place a finger on some of these attachments in here. And I have found that people may have had previous surgery there, and they have a pain right here, or they have a pain over here on the side of this bone. I can do an exam and pinpoint those locations, but sometimes I can't. We've actually done Botox injections through the vagina, believe it or not, in some of these tendons or muscles to make them relax, and I've had good success, and also placing steroids and lidocaine. So that's effective sometimes, but sometimes you almost think you're crazy or you've lost your mind and nobody believes you that you got this non-specific, non-visceral pelvic pain. These are all the large myriad of muscles that are in your pelvis that the commoner doesn't understand. People understand the biceps in your arm, they got that, but there's so many muscles in your pelvis that attach to so many different things. And you basically don't have a standard way of stretching them or knowledge of them to do anything about it. You can't self-help yourself because it's too complicated. Your daily activities aren't moving these structures. You're not educated on how to stretch them or manipulate them or massage them. Well, someone can have pelvic pain for life and have these kind of conditions, and they never really get any kind of resolution. I'm just going to put this at the end. This is a book. Somebody led me onto this book. This is not written. This is written by a physician and some other. This is really a guideline for a patient, not really for a doctor. And it's a self-help book. I will tell you, this book will spend more time telling you about the why than it does the how, mainly because they first need to convince you that, it's not in your head. These are real conditions. There's real things you can do for yourself that are not something you're going to find in a doctor's office. I'm throwing this out there. I'm not going to preach this book. I am going to preach the person who led me on to it, though. This is somebody that owns a physical therapy outfit in Marietta. Her name is Jackie at Progressive Pelvis. There's some physical therapists here in town as well. I read this book, and I must say I'm intrigued by it. This is the type of thing that you can go to somebody that will spend some time teaching you how to take care of your own pelvic pain and learning to understand it and basically conquer it. That basically take over where physicians may have failed. And that will end my talk. And I am open for any type of questions that anybody may have.
Dr. Cullison, we did have a couple come in. Someone asked if someone thought they needed to come see you, how would we go about making an appointment? And do you see patients just in Carrollton?
Currently, we are we are listed, but we're online. We have first of all, we have a website to find out information. That's WG Urology, one word, WGurology.com. Our phone number is 770-834-6988. We have appointments in Carrollton and in Villa Rica. We were seeing patients in Wadowee. These are on hold right now due to the pandemic. Our turnaround on appointments we're not that far booked up, and we take just about every insurance plan.
Okay, and for another one, for those that have had the implants, how successful was it in fixing the issue, and how do they have more or different issues later on? Good
question. I should have addressed that earlier. So this is what I would quote in my office, that when somebody comes in and they have failed conservative measures for either bowel control issues or bladder control issues. Now, I've probably done much more of the bladder control issues than the bowel issues just because they come in larger numbers. But let's just say you come in with urgency incontinence. Well, those that have urgency incontinence, if they set up to do the test, where I told you we put the little needle in you and you wear it for a week, the temporary version, 90% of those people that have the test go on to do the surgery because the success rate of just the test alone is over 90% successful. And then those that go on to get the surgery to have the implant, complications are rare. Complications are rare. It is a foreign body. I have yet to have an infection. I don't want to jinx myself. I have explanted, removed a few over time, but I've only removed one that I can think of because the person, after having it for 6 months, didn't think it was helping them. So again, 90% of the people that signed up for the test for it went on to get the permanent implant, and they don't have long-term complications. If you were going to have a complication, it's going to be right at the very beginning, and I will tell you that that is low in number.
Okay, and would you allow your mom, daughter, or wife to receive the sling knowing it's passed?
Yes, I have family members that have the sling. I have operated on friends. I have operated on staff that I work with in my office and at the hospital. So yes, for the right patient, I find that it is the best for stress urinary incontinence.
Okay, and the last one, I did Kegel exercises years ago, but there was no one who did that therapy in Carrollton. Is it available now locally?
Pelvic floor stimulation, in order to do the Kegel exercises for you to make you a pro at it, yes, those are done here in Carrollton at my office. I believe they're also done at the gynecology office in Villa Rica as well. They were doing that, I'm not sure they're, but anyway, we are doing that every week, and we've been doing it for 20 years. Thank you.